Just so everyone knows, we are recording this session.
Hi, everyone. We'll just wait for one more minute for everyone to join, and then our health advisor, Christine, will start the presentation. Thank you. So, Christine, we can start. You're on mute.
Hi, everyone. My name is Christine Bousquet. I am a health advisor at Concern, and I'm going to introduce this integration session. Maybe before starting, just a few in-house rules. Please keep muted yourself and do not hesitate to write questions either in English or French in the chat box. We also apologize because there won't be any French channel available for translation during the session, but we are here also to support any translation as much as we can. And yeah, I think maybe next slide, Satya, please. Yeah, the objective of this session is really to identify, I mean, we have already identified, but to agree one or two recommendations to better ensure that severe acute malnutrition SAM is delivered through routine health services. I think we are not going to go into details. It has been presented in the previous session. Then we also identified two levels for recommended action, one being the decision maker on policy and funding, and the other one being the implementing partners. Next slide, please. Yeah. The session will take us into a presentation for South Sudan, 10 minutes by our colleague, Frank Aldo Okello. Then it will be the Concern Niger presentation. Yaya Diabete will present in French, but you will see the presentation projected in English. Then Q&A question, 10 minutes at the end of the two presentations. And finally, discussion and agree recommendation will take us through 40 minutes. Next, please. Yeah. So just a reminder on the key points on integration. We all know that SAM is really very essential and often integrated into the protocol and health services package in most countries, even in fragile contexts. However, we have seen that it's not always integrated as much as it should be. And then we learned that it is really critical to focus on the broader child health outcome, especially knowing the burden of malaria, acute respiratory infection, and diarrheal disease, and then trying to link with what we call the integrated management for childhood illness approach. As Kate mentioned, many donors are really supporting the integration of health and nutrition service package, not going in parallel, but trying to integrate to contribute to child survival. However, in practice, it is not always implemented. And we value this positive development, and Concern is really committed also to fully endorse that integration. In some contexts, funding are going parallel, and also supply and medical chain for nutrition and health are not always integrated. They remain siloed, and this poses a lot of challenge in the implementation. And also, for instance, in South Sudan, the Health Pool Fund is supporting the delivery of health services, while UNICEF and others are focusing and funding nutrition services, which is also contributing to parallel delivery of services. Next slide, please. Moderate acute malnutrition are also included in the package of health services. However, for the sake of this presentation, the discussion will be really focusing on SAM management, because it has been the focus in our implementation in both South Sudan and Niger. So the focus will be really some treatment and health services presented as one package rather than going in parallel components. There are, however, as I think everyone knows here in the room, a number of really systemic obstacles to integration. And our colleagues in South Sudan are going to present those obstacles and also the steps they took to address some of them within the health system building blocks, because I think one also behind contribution of ERNE program was really to try to strengthen the health system. And then finally, the such approach will be presented by Concern Niger, together highlighting the opportunities to strengthen the system and how the shift from CMAM search to health search took place and brought some also valuable contribution to the health system as a whole. Next slide, please. So I think now I will give the floor to our colleague, Frank, to present South Sudan integration case study and the main outcomes it brought into the health facilities and also at the district level. The floor is yours, Frank. Thank you.
Good morning, everybody. I'm Frank Aldo Kero. I'm the Health Technical Coordinator for Concern South Sudan program, and I'm going to present on behalf of South Sudan team. Next slide. South Sudan is a fragile state emerging from a prolonged civil conflict and has a fragile state index of 112. And South Sudan has all the relevant policies and strategies for health, wash, and nutrition in place, but its implementation is a major challenge. Next slide. Factor inhibiting the integration of health and nutrition activities in South Sudan. The fragility of the health systems and the limited capacities of the governments, chronic emergencies, and the mindsets of NGOs leading to vertical nutrient interventions. And sometimes the strategies of the donors can hinder integration efforts. Example, one nutrition and one health partner per county. Health and nutrition clusters are not working or coordinating jointly toward health integrations. Example, at account health, there are several meetings of health and nutrition cluster meeting, but seldomly there are joint meetings to enhance coordination efforts. As you can see from the graphs, there are many different sources of funding for medical and nutrition supplies, making the different categories of supply very fragmented and hindering integrations. Example, the supplies for the cellular centers come from 3 different sources. Even the essential drugs are coming from 3 different sources, which make monitoring of consumption and stock very challenging as they are managed by different actors. Next slide, please. What steps are concerned taken? County health departments and concern jointly focus on health facility levels and train and try to explore specific activities based on the health system strengthening building blocks that will enhance integrations among health, nutrition, and wash at health facility level. As you can see from the slides, there are several activities that we undertook. However, I'm just going to mention a few which had a great impact on initiatives and on staffs. We established two-way screening and referral pathways. We also established mechanisms to support each other, did increase caseload through temporary deployment of staffs. We also removed the physical boundaries like fences which were separating the health and nutrition services. M&E system we also set in place to track all the referral from the various departments. and we provided technical support to health facility staff on the stock management. We also mapped out all the list of medical supplies and nutrition commodities from different sources. Next slide. We also focus on community level integrations. As a first step, as I mentioned before, we developed joint training packages. We also scale up family work and ensure that our behavior change curriculums included was health and not only nutrition topics. We also piloted the SaaS approach in one of the facilities, and we found that it greatly helped us move toward an integrated approach. For example, health and nutrition staff discussed about the nutrition admission and mobility trend and how they interlink. Based on the discussions, both health and nutrition staff came up with a joint action plan where they can support each other during the spikes. Some of the lessons we have learned. Overall, one of the major learning that we had was even in the extremely fragile context with major constraints across the health, move toward greater integration of health was. We also learned that we cannot just focus on one aspect of integration, example, human resource for health or the medical supplies, but we needed to take into account all the building blocks of the systems, and all relevant actors need to have a consolidated and coordinated efforts toward integrations. Another critical thinking was that we don't need to come up with a complex mechanisms, but rather take a simple, inclusive, and participatory approach at the facility level to make integrations work. And supporting what's in health facilities is critical to any integration efforts and also to mitigate the risk of outbreak, just like it was in COVID-19. And lastly, the most important learning is that health workers should be at the center of any integrations between health, work, and nutrition services. Way forward, and this is specific to South Sudan context, that despite the success of integration effort, we still don't have answers to several key questions. And one of the major was the sustainability, taking into account the capacity of the government and the funding landscapes in South Sudan. And the second is about the scaling up of the nation lands and the uptake by different actors, including the health and nutrition clusters, plus the governments of South Sudan. And one of the major constraints in South Sudan is the recent strategies adopted by UNICEF and World Food Programme to have one nutrition partner per county, which may limit the scope of integrations. And we still don't know how the future health and nutrition strategies of UNICEF or World Bank and Food Fund programs will look like. So to sum it up, we still don't know how the future strategies of the donors will influence the integration of health, work, and nutrition in South Sudan. This is the end of presentation from Concerned South Sudan programs. Thank you for your attention, and I hand you over the next presenter, who is Yaya. Thank you.
Oh, yeah, so on mute. Okay. Ok, bonjour tout le monde. Je vais donc continuer avec la présentation, vous entretenir sur la transition des imams surge vers les health surge au Niger, partager un peu l'expérience des concerns Niger par rapport à cette transition. Et pour ce faire, je vais vous faire une introduction, un rappel global sur le surge, les différents pays dans lesquels le surge est déployé, vous faire un aperçu global du surge au Niger. Ensuite, parler des étapes clés de la transition du CIMAM vers les health surge pour finir par les apprentissages, les enseignements que nous avons tirés de la mise en œuvre de cette approche surge. Diapo. Donc, voilà, comme vous le voyez ici, le surge, pour rappel, est venu, est né en 2009 à la suite de la grande crise nutritionnelle qui est survenue en 2006. Donc, c'est une approche qui vise principalement à répondre de façon efficiente aux pics saisonniers récurrents de malnutrition, tout en maintenant la qualité des services. Et c'est là à travers 8 étapes interconnectées. Donc, le surge, aujourd'hui, dans le monde, c'est 16 pays qui sont couverts. Et parmi ces 16 pays, il y a 9 qui sont couverts par concern. Et Diapo. Donc, c'est à la suite des constats faits sur la survenue de façon récurrente des pics saisonniers de malnutrition et aussi devant les besoins de maintenir la qualité des services pendant cette période où il y a une surcharge de travail au niveau des structures de santé qui concerne, en collaboration, en partenariat avec la direction de la nutrition, à implémenter l'approche CIMAM Surge au Niger en 2014. Et là, c'était au niveau de 11 structures de santé de la région de Tawa. 7 années après, donc jusqu'en 2021, on a passé 7 ans à apprendre de cette approche à CIMAM Surge et on est arrivé à un certain nombre de constats. Et parmi ces constats, on peut parler de la verticalité de l'approche CIMAM Surge, à l'image même de la PCIMA, qui est resté comme un élément à part dans le paquet minimum d'activité au niveau des centres de santé. Aussi, nous avons constaté qu'il y avait d'autres pics importants, des maladies infantiles qui survenaient et qui souvent absorbaient même les pics de malnutrition. Et ces pics aussi étaient récurrents et saisonniers. Et aussi, il faut tenir compte des prérogatives des centres de santé qui ont vraiment pour mission de répondre à toutes les sollicitations au niveau de ces structures de santé. Donc, ce sont ces 3 éléments qui ont soutenu l'idée de mettre en place une approche plus globale qui va intégrer, associer à la malnutrition, les autres morbidités qui ont une forte prévalence et un fort impact sur la charge de travail au niveau des structures de santé. Et c'est ce qui a amené au pilotage de l'approche Health Surge au niveau des 12 structures de santé en 2021, toujours dans la région d'Ottawa. Et aujourd'hui, le surge au Niger, c'est 494 structures de santé qui font le surge, parmi lesquelles il y a 150 qui font le Health Surge. Et ils sont répartis entre 39 districts sanitaires de 4 régions administratives du pays et soutenus par 9 partenaires. Il faut aussi noter que l'approche CIMAM Surge vient d'être intégrée cette année dans le protocole de prise en charge intégrée de la malnutrition. Diapo. Donc, quand on a fait ces constats, quand on est allé vers la mise en place de cette approche Health Surge, donc une transition du CIMAM Surge vers le Health Surge, on a d'abord commencé par une évaluation des structures de santé qui font déjà l'approche CIMAM Surge. Et cette évaluation a porté sur 3 critères principaux. Le premier critère, c'était vraiment d'apprécier l'opérationnalité de l'approche CIMAM Surge dans ces structures de santé, c'est-à-dire des structures qui font la mise en œuvre correcte des 6 premières étapes de l'approche CIMAM Surge. Ensuite, il fallait chercher à comprendre quelle était la qualité de la prise en charge de la malnutrition au niveau de ces structures de santé. Et cela, on l'a apprécié à travers les indicateurs de performance sphère de la prise en charge de la malnutrition. Et en dernier lieu, il fallait voir les niveaux de fréquentation des structures de santé, les niveaux d'utilisation des services au niveau de ces structures de santé. Donc, ces 3 éléments clés, ces 3 critères nous ont permis de retenir 12 structures pour déployer ces pilotes sur les 94 qu'on appuyait à l'époque. Et ensuite, on est allé vers la revue des outils pour pouvoir mettre en place cette approche plus globale, plus intégrée qu'est les Health Surge. Nous avons ensuite réuni l'ensemble des acteurs qui sont impliqués dans la gestion de la santé au niveau communautaire. Il s'agit des services techniques, des collectivités et des organisations communautaires pour les expliquer ce que c'est que l'approche Health Surge quelles sont les petites différences entre cette approche et les CIMAM Surge, et quelles sont les contributions que cette approche pourrait apporter, et aussi et surtout quels sont les rôles et responsabilités attendues de chacun des acteurs pour que cette approche puisse marcher. Ensuite, on est parti pour la mise en œuvre effective de cette approche au niveau des structures de santé. Et cela est passé par la formation des prestataires, ensuite la mise en place de l'approche, au cours de laquelle mise en place, nous avons identifié, procédé au choix des maladies qu'on va associer à la malnutrition. Et ce choix a été guidé par 3 critères principaux. Donc, il fallait que ce soit une maladie qui ait une forte prévalence chez les enfants de moins de 5 ans. Il fallait qu'en plus de cette forte prévalence, cette maladie ait un impact certain sur la charge globale de travail au niveau des centres de santé. Et il faudrait que cette maladie ait une saisonnalité, une certaine récurrence dans la survenue de ces pics. Et cela nous a permis d'aboutir à la sélection dans la majeure partie de nos zones de 3 grosses morbidités. Et parmi ces 3 grosses morbidités, nous avons le paludisme, nous avons les diarrhées et nous avons les infections respiratoires aiguës. Au Niger, ici, le vocable infection respiratoire aiguë regroupe les pneumonies et aussi les rhumes. Donc ensuite, on a fait le suivi et l'évaluation de cette approche Health-Surge qu'on vient d'implémenter au niveau de ces 12 structures de santé. Diapo. Ce suivi-évaluation nous a permis, de 2021 à nos jours, d'apprendre 4 grands enseignements, de tirer 4 grands enseignements de la mise en œuvre de cette approche Health-Surge. Et le premier, c'est qu'on a vraiment constaté un plus grand intérêt des acteurs, c'est-à-dire que ce soit les services techniques, les collectivités et même les organisations au niveau communautaire, ils avaient un plus grand intérêt pour cette approche qui, pour eux, colle mieux aux missions des structures de santé. Et ce plus grand intérêt a vraiment soutenu leur appropriation. Donc, on a observé une meilleure appropriation de l'approche Health-Surge par rapport au CIMAM Surge. Et cette meilleure appropriation, ces plus grands intérêts ont soutenu un engagement plus important de ces acteurs-là pour la réussite de cette approche. Et cela s'est manifesté quand on a fait une évaluation de l'opérationnalité du surge. Et là, on voit que 62% des structures Health-Surge étaient opérationnelles contre seulement 38% pour les structures CIMAM Surge, selon une évaluation qui a été faite en août 2022. Le deuxième enseignement qu'on a tiré, c'est que vraiment cette approche elle soutient l'intégration de la PCIMA dans les paquets minimums d'activité parce qu'elle fait l'interface entre la malnutrition et les autres morbidités qui sont fréquentes chez les enfants. Donc, elle donne lieu à un paquet plus global, plus intégré, qui permet de soutenir vraiment cette intégration de la PCIMA dans le paquet minimum d'activité des centres de santé. Et le troisième constat, c'est que comme le CIMAM Surge, l'approche Health-Surge contribue au renforcement de la résilience du système de santé. Et cette contribution, elle est basée principalement sur le fait que cette approche va lever les défis de la participation communautaire aux actions de santé, et principalement la participation des communautés au financement de la santé. Et cette participation des communautés au financement de la santé a vraiment permis d'améliorer le plateau technique au niveau des structures de santé. Et cela a porté sur le recrutement par moment et par endroit, la formation et le renforcement continu des capacités des ressources humaines au niveau de ces structures de santé, et la dotation de ces structures de santé en matériel et équipements médicaux, et aussi la construction et la réhabilitation des infrastructures au niveau de ces structures des centres de santé. Et en dernier lieu, un élément important à retenir quand on veut passer du CIMAM Surge vers le Health-Surge, ou même quand on veut faire cette implémentation directe, il faut tenir compte des difficultés de portage de l'approche au niveau central, parce qu'elle regroupe plusieurs sous-directions ou directions. Donc, il faut souvent travailler à ce qu'on ait une sous-direction ou une direction qui puisse porter cette approche et qui puisse en assurer le leadership. Donc, voici brièvement présenté les éléments clés par rapport à la transition du CIMAM vers les Health-Surge. Je vous remercie et vos questions et demandes d'explication, de compréhension sont les bienvenues.
Thank you so much, Yaya, for your presentation. So now we will stop this sharing and we'll start some questions, try to answer some questions. So Christine, have you seen any questions in the chat? Because I can see it.
No, I did not see any question yet. Yeah. Let me check. I think the participants were listening and maybe there was no questions so far, but now please feel free to include the questions in the chat box, either in English or French, and we try to manage them. Yeah, thank you.
You can also unmute yourself and ask the questions directly if you want.
Erin, please. Yeah.
So my question is for Dr. Yaya and the Niger team. What next for Health Surge in Niger? Alors, le Dr. Yaya, c'est quoi les prochaines étapes pour Health Surge au Niger?
Ok, merci bien. Je pense que le Health Surge, jusqu'à preuve du contraire, reste un pilote. Et dans ces pilotes, nous avons fait la transition du CIMAM Surge vers les Health Surge. Et ensuite, nous avons fait l'implémentation directe de l'approche Health Surge. Donc, tous ces éléments nous ont permis d'apprendre sur cette approche. Et on a fait ressortir, comme dans cette présentation, certaines évidences de la contribution de cette approche Health Surge dans le renforcement de la résilience du système de santé. Donc, les prochaines étapes, c'est déjà aller vers une revue. Il y a déjà une stratégie nationale CIMAM Surge. Donc, peut-être s'il y a un soutien, un accompagnement financier, c'est soutenir le ministère de la Santé aujourd'hui à aller vers une révision de cette stratégie pour intégrer les aspects Health Surge, donc pour intégrer d'autres morbidités. Et cela cadre plus avec la PCIME qui voilà, regroupe plusieurs sous-directions qui peuvent être mises ensemble pour porter l'approche. Donc, l'idée, c'est vraiment soutenir d'abord son intégration dans cette stratégie nationale CIMAM Surge qui est là, en mettant les aspects spécifiques au Health Surge. Et aujourd'hui, il y a cette transition entre les CIMAM Surge ou même cette implémentation directe du Health Surge dans beaucoup de zones du pays, même si cela n'est pas encore soutenu par un document ou un portage institutionnel. Donc, il y a un véritable intérêt des services techniques du ministère de la Santé pour cette approche qui est plus globale. Et donc, les perspectives dépendent en réalité des disponibilités et des possibilités d'accompagnement financier. Mais elles restent axées sur la révision des outils qui est en cours actuellement. Et nous avons aussi la révision de la stratégie nationale de mise à échelle du Surge. Et enfin, aller vers la possible intégration de l'approche Health Surge dans les paquets PCIME du pays. Donc, ce sont en gros les perspectives par rapport à cette approche. Mais je suis avec ma collègue Mariama ici. Donc, si elle a des compléments, je pense qu'elle peut les ajouter.
OK. Merci Yaya. I will try to recap and translate the key points. Erin, should I go ahead or do you want to?
I think some of the key points were that there's an interest to see if it can move further in Niger. There is going to be a revision of the tools, which is ongoing. It's going to see if it can be included in the national CMAM Surge expansion strategy and in the CMAM protocols, but it is funding dependent. That's what I understood.
Yeah, and I think Yaya made also an important point that, okay, CMAM search strategy has been integrated within the national protocol, but now the objective will be to extend towards health search and have the health search integrated using what we talked before about using the IMCI approach and trying to really advocate for health search integration within the Ministry of Health more broadly, not only on nutrition department, but maybe the mother and the child health department, yeah, at national level.
Alex, you have your hands up. You can unmute yourself and ask the question, please.
Thank you. I'm just trying to get to my brother who presented around South Sudan, especially around the issues of this integration. I saw he had interesting pieces that he noted, including the family work, joint messaging, wash, health, nutrition, and of course, working with the CNVs and the Boma health workers. I just wanted to ask him, in light of the what we don't know yet, that maybe the two fund managers, maybe UNICEF and others, will put it together as one block for health and nutrition in the future. As we anticipate that, how does the approach that concern whatever they are deploying in Unity, how does it align with the BHI, the Boma Health Initiative? Because we have the CMVs, of course, working with the BHW, whatever the CHWs, and the mother groups. And I don't know. And when I look at the BHI, I don't see the mother support groups in the structure. And neither do I hear him talk about the Boma Health Committee in the conversation as they're trying to reintegrate and have the community supported. So how does the two connect? Because I'm just interested to know how they're approaching it. Thank you.
Okay, maybe we let Frank respond to that question on the BHI, which I think is highly relevant in the context of South Sudan. And in the meantime, I will translate quickly in the chat box for the Francophone speaking colleagues. So please, Frank, I let you responding on that question. Yeah.
Thank you, Alex, for the questions. To begin with, concern is operating in analysis project in Gwinnett County. And Gwinnett County, as you are aware, has been under the L-Pool Fund and free and now transiting to UNICEF World Bank funding. So the BOM initiative in those locations is implemented by the World Bank partner, which is called AID. So right now in Gwinnett County, concern is not doing any BOM initiative program. However, in the facility we are supporting, that is Churchill facilities and White plus Rodia, we already have existing Boma Health Committee who are tasked to manage the facilities. And in these facilities, there are already existing Boma Health initiative workers like the Boma supervisors and Boma Health workers attached to those facilities. So the linkages we have is because in those facilities, we are supporting the CNVs, we are supporting the mother-to-mother support groups. Every month, the Boma Health Committee convenes a meeting in the facility levels to discuss issues surrounding the facilities. And in that meeting, it has confirmed staff, it has the government staff, it has all the volunteers in place. And that's how they share their work experiences and then how they share challenges and how they can support one another. So to sum it up, the BOM initiative in those locations is being implemented by World Bank funding, but we have joint meeting with them on a monthly basis. So in the facility, we have the CNVs. These CNVs, we attach them to the mother-to-mother support groups to support them on reporting and some refresher trainings. But also these BOM Health workers, they also have direct linkages with the CNVs and the lead mother or mother support group in the villages because they work in the same village. The only difference is the BOM Health worker, they do the treatment, the CNVs or how they want to provide the nutrient screening as well as referral to the nutrition side and health facility side. That's how currently they're operating. But as I presented earlier on, this one came across because we have two partners in the facility. We have the nutrition partner and the health partner. But in the near future, if the changes happen that we have one partner in the facilities, then the synergies and integration will really be enhanced. Thank you, Alex.
Thank you so much, Frank. I think it's also highlighted one of the issues that Frank mentioned earlier about the segmentation of the services and the funding scenario. So we don't have much time. We are almost over. So the last question that we're going to take is from Sophie.
Yeah, please go ahead, Sadia. Yeah.
Yes, Sophie, do you want to ask the question? Unmute yourself.
Yes, okay. Good afternoon, good morning, everyone. So yeah, my question was for the South Sudan team to know indeed, because of the very little capacity for the national health system, what they see as the most valuable lessons or elements of the research that has improved, helped the continuation of the services there. And voila, if there is one thing, that they see should really be continued over time, because it will be very challenging given the context to apply the full package, what would they be according to their experience? Thank you very much.
Thank you so much, Sophie. I think I can jump in and answer this question because I was involved with the initial setup and the pilot of the surge approach in one of the health facilities in South Sudan. So yes, you're correct. Like the South Sudan health system is not ready to kind of scale up surge approach. But what we have found that if we can implement at least the step of the CNM surge, the first few steps, which is like doing the trend analysis, sitting together and doing a planning session, coming up some kind of action plan, it helps. So what we kind of identified is that when we started the pilot, health and nutrition staff, which were separated by boundaries and they never talked to each other, they were actually coming together, talking about their caseloads and trying to see what are the linkages between the morbidity and the malnutrition. And they were supporting each other during the spike. So for example, I know at least for one instances, there was an increased caseload in the nutrition side, and one of the nurses from the health facility, according to the joint plan of action, came and supported for like at least a couple of weeks. And same thing happened during a spike in malaria cases, I think in Churchill Health Facility, where the nutrition staffs were deployed. And also they were supporting each other during like screening and referral. The main thing is they came together and they started discussing. It wasn't a separate activities by like different organizations. It was as a team, they were coming together and discussing about all the morbidities and malnutrition status that were affecting and coming up with a action plan. So from my experience, I would say that surge approach is really, really important to bring in integration, especially in fragile context. It doesn't have to go to every step and have the national commitment. You can just follow the steps and it will help your integration efforts. I hope I answered your question, Sophie.
Thank you very much. Yes, and I think it makes a lot of sense. So I think it's a very good message. Thanks a lot, Sadia.
Thank you so much. And we are almost crossed our time. So let's go to the group work. For the group work, let me share my screen with you first. Yeah. Okay, I think here we are. So just to kind of give you an overview of what the group work would look like, based on the presentation that we have heard from Frank and Yaya, we have identified some key recommendations based on our experience of implementing health and nutrition integrated services from the health facility. And we came up with 2 recommendations. So now the task is to kind of go to the recommendations, see what you think about them. If you think they are kind of in line with what was presented or what your experience in health services and nutrition services are. And if yes, what are some of the key considerations that we need to take forward to make sure this recommendation, to make sure the recommendations are being accepted by the relevant organizations, donors, policymakers, and implementers. So we have apologized that we don't have a French translation services, but Christine has kindly translated the recommendation in French. And please feel free to kind of provide your input in the chat box in writing in French or English, or even unmute yourself and just speak out. It's kind of like we will try to compile everything. So how it will happen is like based on the discussion, I will compile the key points in this slide. This slide will look like this because, you know, I cannot write otherwise. And then, yeah, we will present this in the plenary. So the first recommendation that we have is for decision makers on policy and funding, especially targeting government, UN, and donors. And the recommendation is promote integrated funding streams and coordination for health and nutrition services. This is what we want to kind of discuss about and identify the key considerations. Any questions so far? So if there are no questions, please speak out what you, yes, sorry.
Okay, no, I was putting my hand. So yeah, I think I completely agree with the recommendation. I think it has to be a little less vague though, because like nutrition, health services, it can be a lot of things. And I think that we don't want also to be, to go on completely the other side. I know that we are giving it a lot of thoughts here at ECHO to try to frame it, in a way that could be really actionable. And voilà, I think maybe we also have to specify what type of health services are required. I think it depends a lot of the aim of the intervention, but at least in humanitarian context, maybe life-saving, also targeting some more vulnerable groups, such as children, pregnant lactating women, or women of reproductive age. So I think it will be important to be a little bit more specific. Otherwise, we might also end up, as you know, we can have the primary, second, and tertiary levels that could be a bit of a Pandora box like that. And if I may, I would also recommend that we consider in that package, when relevant, in a lot of crisis contexts, it is relevant, the GBV package as part of the health system. And I think it's something we also want to see, as it touches, of course, a lot, the women and in this kind of context. Thank you very much.
Yeah, maybe to complete what Sophie has said, I think when we mention here the services, I think we refer to the package as promoted by the Ministry of Health at primary healthcare level, basically. Because I think OTP and TSFP take place within the context of primary healthcare. So we thought really the primary healthcare, including the basics of vaccination, EPI, antenatal care, and possibly, as you said, SGBV as a more comprehensive package, because it is also affecting somehow, yeah, it has an impact, yeah, especially in crisis context.
Completely agree. Like, yeah, so we need to specify, and especially like Sophie mentioned, the target group also, like which vulnerable group we are targeting. Is the essential service package for children or pregnant lactating women, or a comprehensive package, like primary health service package, the way Christine said. Thank you, Sophie, for that. Any other comment? I cannot monitor the chat box, so if there is something, Erin, Matilde, Christine, can you please also do that?
Yes, I tried to do it while translating in the box. So there is this question from Megan. Maybe you want to read it, Megan? Maybe, yeah, please.
Sure. I don't know if I'm responding to the question, but I just, something that I've found when promoting surge in different West African contexts, or, different, even treatment of wasting at the community level by the community health workers, when we're trying to get some of these approaches into, to be adopted by the MOH, sometimes I've found that the challenge is that they, like surge might be included in the CMAM protocol, but it's not included in an IMCI protocol. So simply because it's not integrated into different types of protocols, different stakeholders don't think that they should be implementing it or supporting it. So I think that it just comes into it just shows the importance of having integrated programming, having all actors work on this. And if possible, you know, if there are different protocols that seem a bit vertical, is there a way that we can integrate CMAM language or kind of sub protocols into larger Ministry of Health protocols? Does that make sense? I just think that, yeah, if it's in different protocols, more people are likely to support it, right?
I think the thing that like I understand from what you're saying is like there are different protocols for health and nutrition, it has a CMAM and inpatient, and surge is included. Not only surge, like, you know, all those integration stuff is included in the CMAM protocol. So we need to come up with a holistic protocol like IMCI. Like when Kate presented that it is integrated in the IMCI protocol. So if surge can be seen as one of the aspect of an integrated protocol like IMCI, then it can be effective. That's what you wanted to say, I think.
Yeah, I think so. I think it's just making sure that, you know, if there's a way to ensure that different actors are working on this, and it's not, you know, this is not a vertical approach, especially health surge. And I think, yeah, the recommendation of including it in IMCI is really important. I think that in theory, it's great. It's sometimes harder to do because, you know, if it's CMAM surge, people automatically think that this goes in the CMAM protocol, which I think it does, but there needs to be advocacy that it's more, you know, it's a horizontal approach and it goes across different health sectors. So yeah, I think maybe that's one way to go, you know, to advocate that it's included in IMCI.
Yeah, I think the presentation that Yaya gave is kind of proved, like actually said what you're saying, that we cannot just focus on CMAM surge. It has to be a holistic surge where you take into consideration all the morbidities and all the caseload spike, and not only focusing on SAM or MAM treatment. So yes, I think we all agree to this, that it has to be seen as a holistic. And the way nutrition is seen as a separate, and CMAM surge and all these terminologies, it is actually hindering the integration itself. It needs to be seen as one package of intervention rather than separate one.
Yeah, I think exactly. I was just gonna add, you know, like another example. I mean, this is a different area, but one thing that, you know, it's Save the Children. We're trying to, you know, promote treatment of wasting at the community level, right, as a simplified approach by community health workers, and trying to integrate that into the ICCM protocol. And one challenge that we keep running into is that, you know, there's people at the health systems level that are saying, you know, this should be included in the CMAM protocol, and there's others who say it should be in the ICCM protocol, and we keep having a block because, you know, there's different people within the ministry that say there's different departments that should be covering it. So I think that's I mean, I know that that's a different example than CMAM surge, but I do think that there's just, you know, sometimes there's challenges in roles and responsibilities because these interventions are horizontal and holistic, but they're being kind of siloed into certain protocols that are not, you know, that other health actors are not necessarily supporting. So that's, I don't know if that's the case in Niger, and I don't know, I think it just depends on the Ministry of Health you're working with, but I can see that being a challenge because I'm running into that now with the treatment of wasting at the community level.
Yeah. Sajia, I think there is a reply from the Niger team, so maybe we could listen, because they said we need to reinforce leadership and integrated coordination. Mariama, tu as marqué de renforcer le leadership et la coordination intégrée. Megan parlait de la difficulté en fait à intégrer l'approche surge peut-être au niveau de tous les départements du ministère parce que souvent les protocoles dépendent de plusieurs départements, donc c'est assez compliqué de le faire. Est-ce que l'équipe au Niger, vous voulez élaborer un peu là-dessus? L'importance de la coordination, en fait, peut-être au niveau national, je ne sais pas, selon votre expérience.
Merci Christine, c'est Dr Diawate. Au fait, par rapport au leadership, je pense qu'on a donné 2 points dans la recommandation. C'est d'abord le leadership, le renforcement du leadership. Ça, c'est trouver au niveau central un service technique au niveau du ministère de la Santé qui puisse porter l'approche. Donc aujourd'hui, jusqu'à présent, c'est la direction de la nutrition qui continue à faire ce portage au niveau du ministère. Mais ça, c'est surtout avec l'accompagnement du programme ERNE. Donc, avec le temps, c'est quelque chose qui va être amené à changer. Donc, il faudra renforcer ces leaderships-là, plus d'implication de la Direction générale de la santé pour servir de point focal responsable voilà, de l'approche Health Surge au niveau pays. Donc, la coordination intégrée, je pense que c'est extrêmement important parce que ici, le sujet de ces groupes, c'est par rapport à l'intégration de la santé et de la nutrition. Donc, pour moi, ça va au-delà des aspects surge. C'est vrai qu'on peut utiliser le surge comme tremplin pour aller vers cette intégration, mais pour nous, il est important qu'il y ait des cadres de coordination intégrés parce que même dans nos façons de faire jusqu'à présent, c'est des coordinations nutrition, des coordinations santé à part. Souvent, ces 2 coordinations ne se parlent pas. Et donc, pour aller vers une véritable intégration, il faudrait qu'il y ait cette coordination-là intégrée et que les 2 éléments puissent se parler. Et voilà, qu'on arrête de parler de nutrition et de santé, mais qu'on prenne la nutrition comme un élément de la santé.
Okay, Sadia, I will try to summarize as best as I can. I think the key point here is maybe there is a need to have a framework for integration at national level, at higher level, instead of having separate departments for nutrition, talking about CIMAM and then not having a really health search direction within the Ministry of Health. So Yaya said that maybe other departments for sure should be involved, including maybe the head of the departments of health, so that really we don't have a siloed approach even within the Ministry of Health. So maybe the key points is framework for coordination, integration, I think, national level. Yeah,
I think it's what, like, you know, it can go under this, because I think we are all saying the same thing, that we need a holistic approach rather than a siloed one. And the SARS one is kind of an example of how it is only integrated within the CIMAM protocol and not considered. Yeah. So any other point, like any consideration, because we talked about the funding constraint, like the way the funding strategies are actually affecting the integration. So any advice, any way, like any key consideration, how to kind of resolve that? I know it is kind of difficult. It depends on the different donor strategies. And it's not easy to kind of say that, okay, you should do that. But as ECHO and BHA, like they have set a great example of like how the push from the donor level can actually enhance the integration at the field level. But as from the South Sudan, we have seen that there are several limitations, several challenges to implementation, and even the sustainability of what ERNE did is like, it's question mark. Like, we don't know actually what's going to happen in future, because it's still a very vertical services, vertical approach. Even the cluster system, you can see that it's a health and nutrition clusters separate. Everyone is like kind of making decisions on their own, and there's a limited discussion about integration. So what can we do? Like, what are things that we can do or kind of recommend to the major actors to support this integration? Any ideas?
Ahmed, go ahead.
Thank you so much. Thanks all for organizing this meeting. So greeting from Addis Ababa, this is Ahmed. So my view regarding funding for
Ahmed, I think we lost you, or is it me?
No, we
I
lost
can't.
audio.
Yeah.
Megan, did you want to say something? I saw your hand up.
Oh, yeah, yeah, so I was thinking, I mean, this is kind of basic stuff, but I think just like advocacy whenever possible. So I know in Niger, the CMAM protocol was updated recently, right? I think Dr. Yaya was saying that. I think, if some of these protocols, through nutrition technical working groups, if we know that the Ministry of Health is updating, like the IMCI protocol, I mean, let's get some surge advocates in those meetings, or to help advocate for this approach. I think it sometimes just is a matter of getting people at the table who know how to talk about surge and how it is holistic, how it is a program that's not just nutrition specific but nutrition sensitive. So literally getting bodies in those meetings where these protocols are being updated, I think can potentially help. I know that's not always easy, but just, maybe just making sure that if there are people working on surge in country, that they get in these types of meetings and are on the board whenever something is being updated at the Ministry of Health level.
Yeah, I completely agree. At least for the surge, we need to make sure that every opportunity we have, we jump in and just kind of make sure it is integrated, because I think we have enough evidence now to do that. But for general health and nutrition integration, I think it's also will help us if we have a joint framework to support, like, for example, don't go for one nutrition partner per county in South Sudan, go for one health and nutrition partner per county. So maybe raising those issues in different platforms is what we as an implementers need to do. Okay.
I think Sadia, sorry, there is a last question we take from Sophie, please.
Yeah. Oh, okay. Yes.
Yeah. Thank you. No, it's not a question. I think it's to feed a bit the thing when you were, asking how can we do this. I think that the understanding in general why nutrition is a different funding from health is that there is some sort of I guess assumption that the health activities are at an adequate or good enough level, let's say. And I think that if we can really identify some gaps, if we can quantify the needs, it's very hard, and I speak from a donor point perspective, it's very hard then to not address it. I think that very often the way we work as nutrition practitioner is that we get in when there is a high prevalence, right? But we don't necessarily see a high prevalence of diseases. So we, in a way, the logic is to say, okay, we want to address the nutrition crisis. I think it's very important for the partner to highlight the fact that, yes, the entry door might be through nutrition, but the health services are really not adequate. And, sometimes we fail to see this data because it's much more complicated. It's a completely different type of analysis, right? That the one we use for nutrition. So I think it's also about really make these needs visible, and really to say, look, it doesn't make sense for us to intervene in nutrition only when you have so many children that are denied, malaria treatment, for instance. So for me, I think it's also just a mindset from our nutrition community that needs some change, and we need to start looking and quantifying these gaps in the health system. And I don't think any donor that sees that there is such proeminent gap could say no, me, I don't care, I just want to fund nutrition. I think especially if we are talking about the young children and mothers. Thank you.
Can you check what I'm writing? I hope that I'm kind of trying to capture what you're saying.
Yeah, I fully agree as a health person to what Sophie said. I think, and the opposite can be true as well. I think so. Maybe try to always think a more comprehensive approach in terms of burden of disease, including malaria, which is the main killer. And sometimes we don't quantify that. We don't pay sufficient attention when we do the need assessment. So I think needs assessment needs to be more comprehensive and always link malnutrition to other causes of illness like malaria, especially malaria, because I think as WHO reports, last report reported, is the main killer in children under 5 still. And I think if we pay more attention to needs, I think we may also pay more attention to the implementation, ensuring the supplies, including the treatment, anti-malaria treatment, rapid diagnostic tests, etc., etc. Yeah, just to.
So do you think that I have captured the gist of what was discussed?
Yeah, I think we can move to the next recommendations, yeah, for sake of time. Yeah.
Okay. Anytime anyone wants to say anything about the recommendation one, just unmute yourself. So the second recommendation actually is again nothing new. What we did is like we didn't focus because of the fragility of the health system. We didn't focus from the top. We targeted the health facility level, and it was like focus on the individual health facility, looking at the building blocks where we can kind of foster the integration, what activities is feasible and it is doable, and where like we can actually make a greater impact. So that's what we did. And we identified that's a very simple matrix. Like I remember like when we were starting to discuss about it, we just kind of opened an Excel file and say, okay, how nutrition stuff can support health facility activities and how health stuff can support. It's just simple as that. And most of the activities we already know is just putting the matrix together, making people responsible, having a timeline, having an M&E system helps. So this is one of the recommendations we want to put forward, that in a fragile context like South Sudan, please focus on practical action plan to guide integration at health facility and district level, and kind of where services for health and nutrition remain quite siloed. So any thought on this? If you don't agree with this, or if you agree with this one, if you have any kind of experience or any consideration you might think that we missed here, please. I'm ready to write. Or was I too fast?
Sadia, can I say something?
Yes, please.
I think that integration is a continuum. And I think before you develop the plan of action, you need to understand where you sit on that continuum. You know, what are your goals for integration? Because in a place like South Sudan, from what I understand, you know, those goals be quite different than like another place. So I understand that you're saying a contextualized action plan, but I think first understanding sort of the strength of integration in that overall system, and then what can be achieved. You need some low-hanging fruit that you're able to achieve so that, you know, there's sort of motivation, and then you need some sort of longer term goals. And I think for me, integration, you know, it can be very complex, but it has to have like a long-term view, a short-term and a long-term view. I think we expect, you know, in a year or two, we can integrate nutrition into health, and that's not really how it works in most places. So I think understanding where you are in continuum, making your plan accordingly, contextualize, have low-hanging fruits and long-term goals. That's my opinion.
I think you're completely right, because there has to be a goal. So what South Sudan did is like, they didn't aim for like, you know, having like an integrated health and nutrition services all over South Sudan. They focused only on the health facility and made sure the CHD involved. So, and what I've seen from what happened next is that the objective was to make sure that the CHD, the county health department, is on board and making sure that the integration efforts are like taking place in the health facility level. But then we need to identify, like when we said, like, you know, for the next stage, like we need to identify what is the next goal. and build it from there. So yes, I completely agree. And this is one thing I think we didn't do quite well. And that's what we need to kind of focus on in the future program, that, okay, what is our like a stepwise goal, and like what are the low hanging fruits, how we can go there. I completely agree.
If I may.
Oh, please.
Thank you. So no, I think also it's important to maybe revisit the way implementing partners see their role in nutrition and health services. I know that I mean, from the visits I do on the field, I see that very often, you know, we put a lot of emphasis on the technical support, which is certainly needed. But sometimes you can tell that the logistic part or the equipment part, or, you know, the getting access to the supply is really the biggest bottleneck in the provision of services. And I think that sometimes it's not easy to accept that, right? That you're going to be saying, okay, we are going to do a little bit of training or on-the-job training, but our biggest added value actually is, you know, having a car basically able to bring the supplies from the health bureau or whatever. So I think we also have to acknowledge that from a very, very pragmatic point of view, and not hesitate to make that shift in the technical strategies of NGOs. I don't know if that makes sense what I what I just said.
I'm writing it. Is it making sense what you're saying?
Yes, yes, indeed. And I think, but I think very often we see the role of implementing partners from a technical side. I think especially in countries such as Ethiopia and Niger, you have a lot of knowledge, you have a lot of capacity there already. Sometimes the biggest constraint would be the outreach or some. So well, I think we also have to be very, very conscious of that and not keep intervening the way we have always been doing, because I think now we are becoming less and less relevant in some contexts. Thank you.
Yes. Yes. Again, like the way Frank also has mentioned that, you know, like you look at all the building blocks, but you cannot solve everything. So if you look at the infrastructure of the building blocks, like there are certain limitations of the implementation partner, like technical capacity is not going to help building the infrastructure, I mean, in a way, but kind of trying to see the low-hanging fruit, as Irene already mentioned, that what can be done to have the biggest impact. So it's kind of like sitting together, all of us, trying to see what we can do. It's not only from a technical perspective, but also kind of addressing the big bottlenecks like supplies and the community outreach and all the big things. I think that's what you wanted to say, right? So
yeah,
exactly. Thanks.
Perfect.
Yeah, I see.
Okay.
Sorry, go ahead. I see.
No, Christine, go ahead.
Yeah, I see Mariama from Niger has raised a hand. Please, Mariama, feel free to talk.
C'est Dr. Diabaté. Au fait, je n'ai pas beaucoup compris, comme il n'y a pas une traduction qui nous permette de saisir tous les éléments, mais je pense qu'ici, c'est l'intégration, un plan d'action pour faciliter l'intégration des services de santé et de nutrition au niveau des centres et districts, surtout dans des contextes comme le Sud-Soudan. Moi, je pense que c'est vraiment tout un processus. Donc, à partir d'une planification intégrée qui va prendre en compte les besoins et les besoins de santé et de nutrition et proposer une réponse pour l'ensemble de ces besoins identifiés. Ensuite, le suivi, la mise en œuvre, le suivi conjoint. Donc, développer un programme intégré qu'on va mettre en œuvre, qu'on va suivre aussi. Et l'autre élément, c'est la coordination. Donc, mettre en place des mécanismes de coordination intégrés comme autre élément du plan d'action et au niveau des bailleurs, trouver, c'est-à-dire aller vers des financements conjoints qui soutiennent et la santé et la nutrition. C'était l'intervention que je voulais faire, quoi. Je ne sais pas trop.
Oui, Oui, j'ai essayé de traduire Yaya dans le chat box, mais je n'ai pas pu tout traduire. En fait, la question, enfin, ce qui a été dit, c'est qu'en fait, les partenaires ne pouvaient, on voyait souvent dans le partenaire le rôle technique, mais qu'en fait, il fallait avoir un peu une analyse ou un point de vue plus global pour prendre en compte tout ce qui peut être aussi des contraintes en termes logistiques, transport, etc. Par exemple, on peut amener un appui technique, mais si on ne peut pas aller sur le terrain et faire, par exemple, des stratégies avancées, mais là, ça réduit énormément l'impact aussi des interventions. Voilà, donc le plan d'action, si j'ai bien compris, devra aussi prendre en compte les contraintes d'accès ou autres contraintes au niveau local. So Sajia, briefly, Dr. Yaya was not sure to have understood. So yeah, because the lack of translation in parallel, but I tried to explain what Sophie said and what you wrote, and he again emphasized the need for integration and possibly taking the donors taking into account that yeah, the funding duplication sometimes, or better funding integration as well. Yeah, so it goes back, I think, to the first recommendation. Yeah.
Okay, thank you so much, Christine. One of the things actually, like the Sophie's point on this, identifying the bottlenecks and where we should focus on actually was got me thinking that we say that we focus on the building blocks, and in the building blocks, one of the major challenges we faced was the supplies. And how, like, I think that you have seen the slides where Frank presented that there were so many actors for health and nutrition supplies that when you go to the health facility, how it will be managed, how the stocks management will be done, there was no idea. And I mean, we struggled. Like it was historically, nutrition technical partner was managing RUTF, RUSF, amoxicillin, and all other stuffs, where health facility staffs are managing all other medical supplies. And it was never seen as like one supplies. Any idea how to kind of break that and make sure that nutrition supplies are not seen as a nutrition supplies rather than it is a health and nutrition integrated supply managed by the same person in the health facility in terms of stock management, consumption, monitoring, and everything. I hope I make sense, but I would really love to hear what you think about it. I guess we don't have any answer to that. Anything, any ideas are welcome because we really struggle with this. And another thing that we kind of saw that whenever we talk about nutrition supplies, automatically it's either RUTF and RUSF. No one talks about amoxicillin, RDTs, albendazole. Like it's kind of forgotten. Or the SC supplies. Any experience that you have, you want to share, or any ideas how to kind of address that?
Yeah, I'm going quickly to translate for the Francophone. Maybe it will be quicker. If you, yeah. So, Yaya, Mariama, and others, yeah, the difficulty in South Sudan was a fragmented medical and nutrition supply chain. Having maybe 7 different funding sources made it very difficult for monitoring stock and also to follow up the continuity of treatment. Do you have any ideas how to tackle this issue of fragmented supply? Anything maybe we can learn from Niger or from previous experience from your side, trying to maybe have a recommendation? Do you think it is important? How could we address that issue? That is not only RUTF or RUS. It's not only pas seulement le Plumpinut, mais aussi l'amoxicilline, le bemidazole, le traitement en fait systématique, etc. Sorry, I am a bit mixing. Oh, yeah.
Yeah, I think that as long as we are dealing with, you know, these very bulky commodities, it's going to be a challenge. I think the volume and the weight itself is a challenge. if you compare with other amoxicillin and other drugs. So yeah, I think simplifying protocols maybe, or having one product only would help. I don't know, thanks.
Yeah. And there is I think a question from Fiona, which is interesting and can lead to more debate. Does it make sense to treat IUTF as a medicine? Not sure if that will help at all, because at the moment it's considered by ECHO as a medical supply for other nutrition supply, nutrition commodity. So I don't know. Any reaction on that? Or maybe Fiona, you would like to elaborate a little bit, or to give
No, I'm certainly not the subject matter expert here. I think there's something in what you're saying there, Sophie, about but about a one product, so that you don't have RUSF and RUTF. But I imagine discussions on that are very lively. I just wondered if it's treated like a medicine, like a pharmaceutical supply, and then managed in that way, at least it's one system, rather than at the moment it's three with multiple different parties involved.
Any other thoughts on this integration or the building blocks? And if you think that, we should emphasize on one of the building blocks more than the other ones, any idea? Or the whole concept of the building blocks is confusing, just be honest. Nothing?
Matilda has her hand up.
Oh, sorry.
Thank you. No, because from an advocacy standpoint, I think this particular part of the conversation is really, really interesting, because I can see there are no straightforward answer for managing the bottleneck of the nutrient supplies. But for an advocacy perspective, if you have one recommendation that you will make to donors related on this, what would it be?
Good question. I hope someone can answer that, because I don't have any answer.
Rita has her hand up.
Please go ahead, Greta.
Hi, yeah, thanks. Listening in here in the background. For me, I'm still wondering why nutrition was taken out of primary healthcare back from Alma Ata days. And in terms of the building blocks, there has never been enough emphasis in terms of tracking budgets for health and primary healthcare implementation, right from national down to district, county, Warada, locality level. I think it gets the least attention among the nutrition world in terms of the building blocks. And likewise, there are no health services without health workers. I think also this is the second important building block, along with the governance and leadership, that gets least attention over.
Okay, the breakout rooms are going to close, and Sajia and Christine, you need to have your slides for presenting ready. So I think that maybe you close the discussion there.
Yes, thank you so much for participating in the discussion, and we will see you at the plenary session. Thank you so much.
Thank you. Bye-bye.